Well, we're here shooting a special edition of our in-session video newsletter.
In
August.
Yeah.
Session ended in May, technically,
Yeah.
but the General Assembly's been in an extended special session since. We finally got a budget adopted yesterday that'll go to the governor's desk. But we've been in this holdover pattern primarily because of the national redistricting efforts, right?
Yeah.
I should say, I'm trying to think back to May. We aren't really in session. I'm dressed down a little bit today. Normally I have a tie on.
I know. I thought I wore a tie because you normally wear a tie.
Oh, I didn't because you normally don't.
So here we are.
Real pleasure to be joined by
Yeah.
our President CEO, Thornton Kirby. Thank you for joining me for this conversation.
Sure. Thanks, Ryan.
Burnaugh, the Vice President of Government Relations for the Hospital Association.
Right.
You've seen a few elections. You've seen redistricting a few times. I've lived through that effort, not involved, but certainly watching our state General Assembly do that.
I don't think I've ever seen a mid-cycle redistricting. That's what was odd about this year, right? They normally do it after the census drives a redistricting, but the president wanted it done for the purposes of getting a little bit more wiggle room in the House. So he called some of our leaders, didn't he, in the General Assembly?
Yeah, a direct phone call from the president to the Senate Majority Leader, the Speaker of the House, the Senate President, all in an effort to increase the number of Republicans in our congressional delegation. You know, we only have one Democrat, but there was an effort really started in D.C. to kind of hedge the bets of the Republican playing field coming up against the midterms. You know, historically, when you've got both chambers controlled by one party and the president in office, that midterm you see a switch in one or both chambers, and so in an effort to hedge against that. But there was a lot of debate in a short amount of time, right? They really didn't have time to get to it.
Yes, he called our leaders much closer to the primary than some of the other states were considering this, right?
That's right.
Remind me, he gave us, they have what, 2 weeks or something?
About 2 weeks.
Yeah.
And the governor actually had to call the General Assembly back into special session. He had another reason. The General Assembly did not have a budget, and we needed a conference report and a state budget. We'll get to that. They passed one yesterday. I guess I should say they passed one on August 11th. That'll go to the governor's desk.
Right.
But the timing meant that with only about a week or so, the General Assembly had to pass new maps approved by the supermajority of the chambers. And by the time they got to that final vote in the Senate, the last day, the soonest they could have gotten there, really, there were already ballots cast. And so there was a real concern by many of the members of the Senate, the state Senate, that you had voters who had already cast their ballot in those primaries, and it just wasn't fair to the and the integrity of the election process.
Yeah, we saw some leadership, some real courage from some of our Senate leaders. Shane Massey, the majority leader, he stood up and said why he didn't think it was appropriate. And then Senator Tom Davis talked about the process they used in previous years that's driven by a census change and all the maps. And they visit every county or every region of the state and build new maps and then have public hearings and input, and all that was expected to happen in 2 weeks. It would have really looked like they were doing it for naked partisan political reasons, not by data-driven redistricting. And I think they just found that really difficult to swallow.
That's right. And give credit where credit's due. Senator Cash from Anderson County that highlighted the fact that votes were being cast that moment, that last day, and that led to a vote that ultimately prevented that redistricting process from getting started.
But that did really interrupt the debate, as you've taught me and others have taught over the years. The last few weeks and days of a General Assembly, a 2-year General Assembly, are crazy and hectic. They're trying to get a lot done. This was really a curveball, right?
Yeah, that's right. There are thousands of bills filed. You know, we operate on a 2-year cycle. As part of the election cycle, our legislative session covers 2 calendar years. So thousands of bills filed. We were tracking well over 200 bills that would impact hospitals or healthcare policy in general. And all of our priorities were kind of up against that timeline right as redistricting came, which we'll get to a few of those. I think the biggest one, and I alluded to this earlier, was the state budget and ensuring funding for the Medicaid agency. And a conference committee met, could not reach agreement, and ultimately they found a way kind of out of the box and established a new fund for what they call community enhancements or investment projects, earmarks, as well as some funding for Scout Motors, and that allowed them to get past the finish line and send the governor a budget just this week.
So on the 11th, they did take the action. We're filming this on the 12th. It was yesterday, but the viewers may not see it for a few more days. What did they do with the budget? Our big priority was Medicaid, having it fully funded.
That's right, and they did. They fully funded the ask from the agency. Our concern was that both the House and Senate versions not only didn't fund the full request from the agency, but did not meet the minimum threshold to maintain current access and benefits for our traditional Medicaid population. We're a non-expansion state. We're not asking them to do more than we're kind of required to do. But if there had been enough of a discrepancy between what was appropriated by the General Assembly and what the agency requested for that maintenance of effort, including a change in the federal match because our per capita income is going up, requires the state to invest more, changes to the way that the Medicare premiums work in tandem with Medicaid, as well as just the general population demands and increased costs of health care overall. All of those factors had us pretty nervous walking into this budget conference committee that has been meeting over months now, that if they didn't get there, if they didn't find a way to creatively fund that, there could be rate reductions or other. Fortunately, through those discussions and the way that the budget rules work and conference committee rules work, they were able to fully fund the agency, and that means there won't be any reduction to access or services for our beneficiaries that are eligible.
And that was one of the things, as you know, that our board said was a very, very high priority. Coming off the One Big Beautiful Bill and its devastating cuts to Medicaid, our board said, please, let's not let the state add to that problem.
That's right.
And at least fully fund the maintenance of effort. So that was a big win for us, because what we don't need right now is to have hard conversations about what Medicaid is going to stop paying for. So we've averted that problem. And I do think I want to reiterate what you said about the changing FMAP, because I think our members need to learn that, as we have learned more about it this year, for future conversations. When the agency says there's an increase in the maintenance of effort, the cost of keeping the program on par, that it seems like that must be inflation. There is an inflationary part of it. There may be some new services that have been added, but the primary thing that's driving that is the fact that as our state gets wealthier, the feds put less in, so the state has to pick up more of the share. We're going to have to keep that in our messaging going forward, that this isn't making anybody, not paying anybody more, not inflation. It is just the fact that as our state does better, the feds back away a little bit.
That's right. And the federal government, we ran into this with the One Big Beautiful Bill debate, right? That they're looking for ways to control the increase to the national deficit. And this is one of those mechanisms in which the federal government can pull back a little bit of their match. It highlights the success from state leadership that our per capita income is going up overall, but it comes with that caveat that the state's got to pony up some extra funding.
Okay, let's go to the next one. How about HALO? One of the big things we worked on this year was how do we impress upon the General Assembly that violence in hospitals is increasing in healthcare settings. We want to ensure the safety of our workers. Legislative leaders did not like the idea of increased penalties as much. They said they wanted to put us in the HALO bill they were working on already. Where did that end up?
Yeah, so the enhanced penalty has been our approach for years, and still I think we collectively agree that that's in the best interest of our healthcare workers. But there's some pushback from those in the General Assembly that you don't want to treat one class of citizen differently than others. And we can disagree on that, but ultimately we didn't have the votes on the enhanced penalty bill in the House. For the HALO Act, designed primarily for first responders, it's an acronym helping alleviate lawful obstruction. It's intended to protect first responders and give them a tool to use when they're responding to a scene outdoors. It says, hey, public, you're welcome to see what's happening. there's no issue there, but you do need to give me space to work. And it's designed to create a 25-foot ring around that first responder. Well, in conversations we had with the legislative leadership on both sides moving into the 2026 legislative session, this idea of tying that approach for first responders and law enforcement to healthcare workers was one that was presented to us. And if that was an opportunity to provide some additional protections for our healthcare workers, we were going to jump at that.
Absolutely.
Unfortunately, as the debate moved forward, what we saw was a focus on emergency healthcare workers, or just healthcare workers in the emergency department, not all healthcare workers. Additionally, trying to enforce a 25-foot parameter around a healthcare worker inside the walls of a hospital gets pretty complicated.
Very different than around an EMT or a paramedic.
That's right.
Or a police officer.
That's right. Heard several folks mention, this idea that there might be basketball court kind of lines, free throw lines all throughout the hospital, just so you know where you can stand and where you can if there's a procedure or a healthcare worker. So we were able to negotiate with them, language permitting up to 25 feet, right? That taking into account the walls of the patient room or the door, but providing that same protection for the healthcare worker. I need space, friend, family member, to do my job. Let me do my job. Again, not our ideal approach, but it was fundamentally a step in the right direction. Ultimately, when that bill reached a conference committee, so we're talking about 3 House members, 3 senators, different versions have passed both chambers, they've got to find agreement somewhere. The conference committee felt like they needed to have a provision in the bill that would allow those two issues to be separated should there be a challenge in the courts, meaning that outside protection for law enforcement versus inside the hospital wall protections for emergency healthcare workers. That free conference power that needed to be granted to that committee by a vote of supermajority from both the House and Senate ultimately failed. And it failed in large part because there were constitutional disagreements in interpretation of what's allowable, what's privilege, what's a right as it relates to those first responders and their protections and the general public. We kind of got caught in the middle. So we didn't want to be approaching it from this way. It was a unique opportunity. And when the General Assembly met the same day they took up the budget on the 11th, the House was unable to pass that free conference powers authority. And so ultimately the HALO Act will not pass this year. And we'll try again in 2027 for protection. So
disappointing for us, but as you said, the legislative leadership was sympathetic to our issue. They chose this path, asked us to go with them. We did. We were really disappointed they couldn't get it across the finish line, but we'll keep fighting the fight.
Yeah, I think that's a good point. I don't know that we spoke to a single member of the General Assembly that said, I'm against this idea. Some of them may have been against enhanced penalties. Some of them were against putting in HALO, but they're all sympathetic to our issue.
The what is not a problem. The how is their problem. So we've got to keep working on that. All right, what about medical malpractice? That was our other big issue. We got very close to the finish line on that one as well.
It was, and we did. We were really fortunate last year in 2025 to be included in a comprehensive package introduced by the Senate Majority Leader Shane Massey. Worked with the Senate on that process and ultimately got a bill over to the House. The House leadership took a different approach. Again, the two chambers often look at things differently and decided to disconnect several of the components to that comprehensive law and took up medical malpractice. And SCHA testified, I testified, we had folks from our hospitals come and meet. We had a big meeting with legislative leadership on the House side. And it was March until we saw that bill start to move, March of 2026, as a new standalone piece of legislation, not the bill that had passed in 2025. So another instance in which the clock was kind of ticking and up against us before there was any discussion about redistricting, right?
And let me interrupt you and say, we knew that was going to be a problem. The Senate knew that was going to be a problem. Shane Massey encouraged us, Senator Massey, to go and work with the House early. We did. We met with House leaders even before the session. We impressed upon them. The conversation began, but they got distracted by some other bills. And whenever you get behind other things like the budget, you have put yourself, they're left in a really tight time crunch.
That's right. There are 18 weeks, calendar weeks, where the legislature's in session. They typically take one or two of those off. Certainly the House does after their budget debate. And that's where we ended up. There is a House rule that allows any House member to formally request a hearing on their bill, and that's essentially what happened to us. The House Judiciary Committee got stacked with these requests that required a subcommittee hearing on this or this or this, and it unfortunately meant that we were not prioritized until it was almost too late. Mm-hmm. Fast forward to the Senate. The Senate had time. They debated this issue, but there was some fundamental disagreement and concern about what would happen to some of our smaller hospitals if the caps and the penalties on a medical malpractice claim, the non-economic damages, the penalty were to increase too much.
Yeah, and let's talk about it a second.
Please.
We wanted two things. We wanted the definition of occurrence fixed, and we wanted gross negligence to be addressed. The cap increases were essentially a trade-off that we were asked to concede to make that a fair swap. And so the Senate didn't like how much the House increased those caps, right?
That's right.
And so that's where, had they done exactly the same thing the Senate did, this bill might have gone on through. Mm-hmm. But they were so far apart that there was an ideological or conceptual disagreement that was pretty tough to bridge.
Yeah, I think fundamentally, both the House and Senate agreed that the definition of an occurrence of negligence needed to be fixed. The exception for the gross negligence cases needed to be removed because there was no formal definition of gross negligence, and there's precedent set in previous cases. Mm-hmm. And then if the caps were increased, it needed to be increased in a way that wasn't overly burdensome to the hospitals and systems.
To the hospitals and to the other entities of the state budget that the state has to cover, counties, sheriff's deputies, sheriff's offices. So yeah, so there were implications for a much broader. Now, we didn't want the caps to increase. That was really a question of, was it politically necessary? So it's ironic that the Senate didn't pass the House version because they thought the caps were going up too much. They were more sympathetic with us. So once again, we're going to have to find the common ground next year.
That's right. So we'll engage with that first thing. Our team had a meeting this morning to talk about our priorities for 2027, and that'll be top of the list again in 2027.
Good.
Both of those, really, workplace violence and medical malpractice.
All right, well, let's do a quicker rundown on the other things we were tracking. Some of them we wanted, some of them we had to react to. So how about hallway beds?
Hallway beds, support from the governor's office. The Department of Public Health ran into this issue where they felt they were their hands were tied. The regulations allowed for our member hospitals to put a bed outside of a patient room when under a justified emergency, but the state fire code didn't allow that, and the Department of Public Health didn't feel like they could enforce or defend a regulation that ran counter to the state fire code. So we were able to get that through both the Senate and House in pretty quick order. Yeah. And now, in a justified emergency, a number of categories that fit that definition in state law will allow a hospital to put a patient in a bed outside of a room.
Right, and that includes things like mass casualty events, bus accidents, pandemics, and importantly to us, whenever the number of patients in the ED exceeds the capacity of the ED, the number of rooms. That's what we really disagreed over, but we got that resolved. So check in that box. That was a help to many of our hospitals, Absolutely. Particularly the level 1 trauma centers, which cannot go on diversion and say we can't take any more because that they're the kind of the top of that food chain.
Yeah, we're really fortunate. Everyone wants to live in South Carolina, and that increased population comes with increased demand.
That's right.
And on those facilities that are often landlocked or in these urban areas, they have a limited number of rooms, and we need the flexibility for them to be able to serve
This is a conversation that's going to recur with all that growth, so we'll have
Absolutely.
to talk more about that. How about the Rural Emergency Hospital designation? This is a federal reimbursement classification that some hospitals, some smalls, might want to use in the future, and our Department of Public Health previously did not recognize that as a category of licensure, right?
That's right. The federal government says that the state needs to recognize a rural emergency hospital and needs to have a definition for that somewhere, whether that be regulation or statute. We felt the most appropriate place was statute, so we amended the definition of a hospital in state code of law to allow for this designation. And it essentially means in a rural area that hospital could stay afloat through enhanced Medicare payments and a monthly stipend. They would have to give up a few things, inpatient services, some discounts on pharmaceuticals, but it may be the difference between that community having access to an emergency department in a hospital or not.
Right, right. So a really narrow subset of our hospitals are likely to care, but for them it could be critical. So great job. And I should say our colleagues and friends over at DPH and HHS were all on board helping to make that happen.
That's
so
right. And just worth mentioning that DPH was also very supportive of our efforts on the hallway beds too.
Yeah, right. Okay, how about patient-friendly billing? That's one that we've gone around and around for the last couple of years.
Yeah, it's a tough one, right? As a consumer, I want to know what I'm paying for. Unfortunately, and I'm going to steal this from you, you've taught me that hospitals are really price aggregators. We don't really set the price. What this legislation wanted from hospitals, and in spirit we agree, show the patient what it is they're paying for. But it's not solely up to the hospital. There are other factors primarily including their insurance. And there were some discrepancies on what the language in the bill said versus what the sponsor was really after. And so fortunately we were able to work with the bill sponsor, change the definitional language, and so any patient now that goes to a hospital will receive a patient-friendly bill, an executive summary of what care was given, what they paid for that care, and if they want, they can certainly request an itemized, detailed receipt. Some of those itemized, detailed receipts could be 40 pages, though. You're talking about every little surcharge for every supply, piece of equipment, point of contact while you're in the hospital, and that felt like it would be more confusing to the patient.
We started out with a requirement of mailing that to their home a couple of years ago, so we've come to a much more rational place. That's a good result, even though we probably wouldn't have preferred it to be codified in statute. We did work. Our team worked with the CFOs and their managed care teams and all to make sure we could live with the outcome.
That's right.
So good. Okay, what about surgical smoke? That was another conversation that's been swirling around.
You made a joke before I could.
Yeah, go ahead.
It's asking for it, right?
Yeah, it is asking for it.
It's a serious issue, and our hospitals take it seriously. I think our problem with this effort from the outset was it was a mandate, as originally drafted, a mandate on all hospitals to implement evacuation technologies and supplies within every operating room to mitigate surgical smoke at the source of the smoke itself, right? So SCHA has done a lot of work in surgical quality and improving that process. And one of the reasons why we have surgical smoke is because those laser devices are safer for the patient than an old scalpel. That creates smoke, which is often carcinogenic and can be problematic for the providers in the room. And so many, if not most of our hospitals right now have evacuation devices within their operating rooms when they're performing surgeries to alleviate that. This concern that every hospital operating room would need to be equipped with a very specific type of device was our immediate pushback, that we could work on this from a collaborative approach with the interested stakeholders and parties. Ultimately, we got to a good place with those pushing for legislation in which our hospitals would be required to mitigate smoke to the extent possible within an operating room, with some caveats for small facilities with minimal, a low number of operating rooms would have a little extra time to implement those policies, and that every hospital adopt that policy. I think it was another timing issue, frankly, where the bill passed out of the Senate quickly, moved to the House, and the House kind of ran out of time to take it up. we're supportive of it in that form, in that agreement that we reached last year, and I expect that'll be introduced in 2027.
So we actually got it where we could live with it, and it didn't pass.
That's
not
right.
because of us.
That's right.
Just because of the circumstances. So, okay, so we think we can live with it if it comes back. How about physician non-competes? That was a bit of a thorny conversation early on. Our board chose not to take a position because all of our hospitals didn't agree with that. What happened in the General Assembly?
Yeah, it's a tough one. It's not often these days where we see debates on the House floor and the votes are close, right? Typically, the vote is unanimous or it's across party lines. We've got a supermajority of Republicans in the House. So they're usually pretty straightforward debates. This is one of the few examples in 2026 where the vote margin was really close. I don't recall exactly what the numbers are, but it was 50 to 60-ish, right? It highlights that there's a big discrepancy and disagreement among some independent private practice physicians and our hospitals who have large physician practices where they're employed by the hospital. Mm-hmm. And many of our members want to retain the physician non-compete ability in their contracts. We only had a couple folks in our organization or members of our association that didn't want those. Ultimately, we stayed back, and the Senate, I think, went through a very healthy debate process once they saw how close that vote was in the House. Testimony, hours of testimony in subcommittee, even in the ceremonial committee room above the Senate chamber while the Senate was in session, they were debating. And we saw a lot of really compelling testimony from physicians on both sides of the argument. I expect we'll see that revisited in some way in 2027. But it's an interesting debate that we're kind of on the sidelines.
Yeah, and I would say that sometimes it's uncomfortable for us to be on the sidelines of a debate that is important. But our board, I give them credit, they said, this issue is important, but we need to keep our eye on the Medicaid budget, the Med-Mal, and the protection of our workers. So we're not going to try to put a fourth one in there. We will just work this individually, which I appreciated the fact they were willing to say the community of hospitals, the collective agenda needs to be the top priority. And that's why we worked what we did.
Our hospitals being divided on that issue, despite the fact that the priority of the association and the collective priorities were what they were, meant that our individual members spent time and energy and effort and capital on an issue that was separate from our priorities, our shared priorities. And unfortunately, that's just how it goes sometimes.
Yeah. Well, that's something we're constantly learning, and our members are constantly learning about the finite nature of political capital. You can't ask the General Assembly to focus on 10 things for you. They'll
right.
focus on a couple.
That's right.
Let's go back over to the federal side now. Let's talk about the elections. Elections 2026. It's kind of amazing. This is an election year, but we just had a primary this week, and we're going to have a runoff in a couple of weeks because of Senator Graham's untimely passing. This election cycle has been odd and continues to be stretched out.
It has. We spent some time unpacking redistricting and the implications there. The gubernatorial election this year. For the first time in 10 years, an open race for governor, really the first time in 16 years that
you didn't have an incumbent.
An incumbent that isn't running to hold that office. And that's really going to set the tone for what South Carolina policies look like over the next 4 to 8 years in a way that hasn't happened in recent history. With the late Senator Graham's passing, there was a lot of debate over who would fill that seat. And his sister was tapped by the governor to serve the remainder of his term, which I feel like was an appropriate. She's certainly been close to the late senator and his staff and could kind of step right in and manage things for the remainder of the term. And then we saw a really crowded primary field. It's not often that one of those seats is open and available. Right. And it's certainly not often that it happens in a special election, right? And so the primaries in June happened, the runoffs for those primaries happened, and now here we are in August with a pending runoff, August 25th, between Darlene Graham and Ralph Norman, current congressman, but soon to be vacating that office.
Right. And a lot of head scratching in the Republican Party in the state about who should be the banner, carrier, or who should carry the standard. So it'll be interesting to see how that one works out.
Yeah, it highlights the still very impactful position from the president, right? He endorsed Darlene early on before she even put her name in the hat. We saw her at the top of the polls and top of the results in the runoff or in the primary, and we'll see how it plays out in the runoff. A lot of qualified candidates in the field, and now the voters will have a choice between those two.
Interesting. All right, so how about looking ahead to 2027? We've got state and federal conversations that are going to be priorities for us.
That's right. On the state side, we talked about medical malpractice and workplace violence. Those will be at the top. There will always be budgetary pressures, especially with the actions the federal government is taking on affordability and lingering or pending implications of OBA. The workforce challenges right now are really acute. Right. We mentioned the increased population. Many of those are retirees. The state's population was already aging prior to COVID and prior to this significant influx of population, primarily from the Northeast and the West Coast. And so that's only going to exacerbate our workforce needs. So we're really looking at a workforce package. How do we address technician shortages, allied health shortages, educational pathways for surgical technicians, alternatives to get folks in those positions? How do we work with the Department of Employment and Workforce and other entities, the technical colleges? Dr. Tim Hardy, the president for the technical colleges, is on our board, which has been a huge asset, but really focusing, I think, at the state level on what we can do to enhance workforce. At the federal level, in a lot of ways, we're in a wait and see, right? What happens within the midterm election? Do we see the U.S. House flip from the Republicans to the Democratic side? We assume the Republicans will hold the Senate. What does that mean for the president's agenda? Our biggest concern is, again, back to the Medicaid cuts and OBA, some of the CMS rulemaking around what a state-directed payment program looks like, or provider assessments. 340B will be at the top of the order. Congress seems to agree that issue needs some resolution. We would certainly benefit at the state level from seeing the federal government tackle that in Congress to try to balance out some of the competing interests there.
Yeah. From my standpoint, I think the biggest issue before the hospital field nationally is probably Medicaid. And as you noted, the One Big Beautiful Bill was really a tax bill, and we got caught up in it as a Medicaid interest because it was the pay for. That's how they paid for the tax cuts they wanted to grant. But it had a very heavy impact on Medicaid. In this state, it's about a $15 billion impact over a decade, which is a lot for the hospitals to absorb by themselves. So it'll be interesting to see if the Democrats take control of one body of the Congress, whether that changes the leverage on that topic, whether they want to revisit it. And of course, then before the law gets implemented, we will have another presidential election.
That's right.
And we'll see whether we have a Republican or a Democrat at that time. One could imagine that you get a Democratic House and a Democratic president in 28, this thing might not be implemented in the same exact posture that it was passed, which is not unusual with big pieces of legislation. Congress often comes back and makes adjustments to it. So that's going to be one of the big conversations for the field in 2027 is, do we have room to renegotiate the cuts?
I think it's important to acknowledge and show gratitude to our congressional delegation. They made sizable efforts to protect South Carolina as a non-expansion state, leveraging the state-directed payment program to the extent that we did.
Congressman Fry and Senator Scott.
Absolutely.
Boy, they were champions.
They really were. So hopefully we can rely on that similar kind of engagement from our delegation next year and in 2028 as we see how things change and what opportunities there might be.
Right. Okay, one last thing. our hospitals did a great job showing up at the State House this year.
Man, they sure did.
We need to get them to double down next year. I know that our team, Evelyn, is working on that with you and making sure that we have a good plan for them and that we have the right messages for them to carry. But you had to feel good about that. Your team had to feel good about that.
Yeah, I mean, huge kudos and acknowledgement of all the effort that the team made this year on all the fronts. This was, in particular, a new effort. The board was super supportive. Many of our CEOs and board members told us, give us a day, we'll be there. And that visual presence does a lot of things. Primarily, it shows the elected officials we're here and we're paying attention. And there was one point at which the clerk of the Senate even asked, I'm looking up into the balcony to see who's here today. And members began to expect it. And we want to leverage and move forward the momentum and that precedent that we set last year and enhance that visibility even more in 2027 and 2028.
That's great. Well, it's going to be another interesting session. We have a lot to do before we get there, but thanks to you and your team for making sure we put our best foot forward, we coordinate well with our members, and that we are present at the General Assembly.
Thank you for your leadership and all the support, and to our board. They really helped guide us on what our priorities were going to be. I don't think there's anything else we could have done to get our priorities across the finish line. It's ultimately a timing issue, and we'll be back in 2027.
We'll look forward to it. Next month in September, our board will have the fall retreat, and we'll be setting our priorities for 2027. So you'll get your marching orders, and so will I.
That's right, we sure will.
Great. Hey, thanks for doing this.